Welcome to the Growth Lab. This is the podcast dedicated to the business of beauty and vitality. Today, we are sitting down with Mike Daniels, the CEO and president of We Treat Podiatry. It's an amazing service that features podiatry. Let's find out more. This episode is brought to you by MedSpa Accelerator. We help medical practices and med spa clinics solve the bottleneck of inconsistent, unqualified patient leads to achieve a predictable, scalable monthly revenue without staff burnout. We're absolutely thrilled to have Mike join us to discuss the future of patient care and his unique treatments. Let's get started. Good afternoon, Mike. How are you?
I'm doing well, Jason. Thanks for having me. How are you?
I'm doing very well. Thanks for asking. I'm excited to dive into your story, Mike. I like to frame these conversations simply past, present, and future. We want to start with your origin story, which is how you got into this demanding and rewarding industry nearly 2 decades ago. And then we'll pivot to your present reality of what's working and what's causing friction and what's keeping those doors open. And then finally, we'll look at the future outlook, which is your vision for the next 3 to 5 years and the biggest strategic moves that you're planning. And that way, we'll be able to cover the full spectrum of building out a successful clinic, or in your case, multiple clinics. Does that sound like a good roadmap?
Happy to do it. Yes. Thank you.
Excellent. So I guess my first question is harkening back to your origin story is, you've been the chief medical officer and president for about 24 years now. Is that right?
It sure is. Doesn't seem like that long, but it's been a while. It's been a minute.
Did you always want to do podiatry?
When I was in college, my grandmother was a diabetic and had a diabetic foot wound, and I went to her podiatry appointment with her, and really was interested in what her podiatrist was doing. So I started to explore that, and I think back to it sometimes and think it was pretty criminal for them to allow me at 18 years old to decide what I was going to do with the rest of my life and to borrow $200,000 to do it. But I did. I went through podiatry school and did residency at the University of Maryland, and now I've been in practice since 2002.
Wow. Okay. That's pretty amazing. Tell me a little bit more about the impressive amount of clinics that you have right now on the Eastern Seaboard and how is it growing so exponentially? What's the secret to your success?
I will tell you the secret to my success is to be careful what you wish for. You just might get it. When I started out, I was an employed physician working for somebody, and I figured out pretty quickly, hey, wait a minute, I'm doing all the work, and he was getting all the money, and that didn't seem right to me. So I thought building a company this large would be, beneficial, and maybe I could work a little bit less or not quite as hard. My personal edict doesn't really allow me to do that. I am a workaholic, unfortunately. I don't really want to be, but I just am by nature. So, I just started acquiring practices and building, and, now we are 11 offices with 10 physicians. We have 3 ambulatory surgical centers, a durable medical equipment arm. We have a PCR microbiology lab. We have a billing and consulting arm. And we just try to be a full-fledged foot and ankle center where we can provide all services for our patients in-house without having to send them to multiple different locations for different services.
Okay. So I just want to take a step back really quick. You saw the opportunity because you noticed as you were working for somebody else, you were doing most of the work, hence you being a workaholic, as you said, but you weren't really reaping the benefits of putting all those hours in. So that's when you decided to flip the script and become the business owner yourself and acquiring those clinics, if I heard you correctly.
I think that's generally a good summary. Obviously, as I went through the process, I didn't quite understand that. Now I understand it looking back on it. I tell the story of about 2007 when we hit $1 million in revenue for the very first time. And, I was walking around strutting my stuff thinking I smell better than most people. And you can use the expression yourself. But I kind of began to realize that I didn't have any idea what I was doing. I really was pretty clueless. And, we were starting to get into dollar figures that, from my perspective, were large and scary. Me, even today at that time, $1 million is a lot of money. And, what happens if it goes away tomorrow? What do you do? So I went to business school. I did that online at night. I would come home from work and I would spend
When did
about
you
two
do
hours.
that? What year was that?
2013, 2014.
Okay.
I would sit there and it was a competency-based program. So I would literally come home and I would sit at my computer for about 2 hours every night writing, and I would do 4 to 6 hours on Saturday and probably another 4 hours on Sunday. And I did that all the way through until I was able to graduate. And then when I graduated and took a look, I realized, oh my gosh, I certainly don't know what I'm doing. Started to kind of talk to people and try to get more advice. The problem was, is at that point in time, so, you're talking now, 10, 11 years ago, there weren't really a lot of roll ups in medicine. They were really starting to happen, these private equity roll ups. So doctors are notoriously poor business people, myself included in the past, and really don't have an understanding of how to do this. We have a natural aversion to the concept of debt, where from a business perspective, debt, if used properly, is actually a good thing.
Hmm.
If you use your dollars to make more dollars, that's a good thing. If you use your dollars to just spend your dollars, you're falling behind.
Hmm.
And, I took that approach to it, trying to reinvest into the business and just to keep the business growing. And then I got to the point where I took a look around and realized, there's nobody my size or bigger to come buy me. So that was probably about 6 or 7 years ago, right before COVID, when these PE rollouts were just starting to take shape. And I started doing a lot of talking to them, both from a professional standpoint as a consultant, trying to explain the podiatry market and how things work, as well as looking for a potential partner, which I have yet to be able to find. Because to jump ahead really fast, just because it's a good opportunity, the future is private practices getting rolled up, and we can go back to that in a few minutes. But that's kind of where we are, because it's getting hard to be an independent practice out there, and there's definitely an economy of scale that happens with size. The problem
Hmm.
with size the more size you have, the more middle management you need, and that becomes very, very difficult in a small business. And we're, as I said, 50 employees. We're a small business at the end of the day. So, we have 10 doctors, which means we have 40 support staff, 4 support staff for every doctor. I who's think is a ratio that is way too excessive, except when we start looking at where we could trim, we can't find a place because everybody's essential. So, you
Hmm.
need that economy of scale where you're getting enough revenue in with the amount of, we're getting the most out of your, per person, you know, uh, unit of labor to make it worthwhile. And that's that sweet spot. And, even with a business degree, I still have trouble kind of trying to figure that out, trying to figure out where we can reduce costs, what the future of outsourcing or virtual assistants really is, and what technology we can use to, make things more efficient to increase revenue. It's more working smarter, not harder, is probably the way to think about it.
Yeah. Okay, great. Gosh, there's so much information in that answer. I guess my follow up to that is tell me a little bit more about that private equity roll up and how it's a challenge for an independent practice to be out there. What is a private equity roll up?
So private equity is a group of pooled money, either from investors or from family offices, where they group together and they search for businesses to buy, expand, increase EBITDA, and sell. And it almost becomes a whisper down the lane, or um, musical chairs kind of scenario where everybody buys it to grow, to sell it to somebody else. And there were certain firms at certain sizes that do things. So, when you're down, in the kiddie pool with me, in the, $1 million EBITDA or less range, you
Hmm.
have these very, very small boutique firms. Usually what it is it's people who out of college went to work for a big three, like a Blackstone or a McKinsey. Got into a good couple of good deals, made some, what I would consider serious money, a couple $1 million, and pool it together and then try to do it on their own. And, they're looking at, companies with, between 2 and 10 million in revenue and $1 million in EBITDA. And then they're looking to find a bunch of those and consolidate them together. And when they do, and then they get it to 5 to 10 million in EBITDA, then they're looking to turn it over to the next level of private equity and so forth and so on. Either you end up going public at the very end of the road, or you end up without a chair when the music stops. One of the two. But that's kind of where those come from. The problem is when you sit in a room with doctors and you sit in a room with business people, they will argue about different things and have no idea they're not speaking the same language. One of the things that I realized and what I learned in business school was just the vernacular. It was so important because it doesn't exist in medicine. We have our own language, our own way of thinking, our own way of doing things. And, we still live in a world where, and I'm no different. If I get really frustrated at sometimes, it really will become because I'm the doctor and I said so. It's like the default position of every physician ever. And I don't mean that like we're all like that all the time, but if you get frustrated enough and you think you know what's best for the patient, that's what you end up saying, or at least thinking.
Mm.
But the business guys don't do that because everything they argue about, everything they discuss has to be on a spreadsheet. They will not have a discussion about something that isn't on a spreadsheet, which is interesting because most doctors don't know how to read spreadsheets. Um, you know, and when you start talking about practice financials or business financials and understanding the difference between EBITDA and cash flow and profitability, it's a very, very different game than most doctors who traditionally have looked at their bank account every day and said, okay, there's a good amount of money in there. I'm good this week. And
Mm.
that's really where the difference comes in. It's those two portions that kind of clash together. But that's where the market is going, and there's been huge roll ups of medical practices. There's a big emergency medicine one, acute care. There's a big anesthesia one. There's a couple of them, Napa being one of them. A whole bunch of these specialties, and there are a couple of companies right now that are starting to roll up podiatry practices. And eventually, my thought is they're gonna roll up and then somebody will buy two of them and put them together and then roll them up and then they'll do that again and again. But when you look at podiatry as a whole, from a professional standpoint, there's roughly about 50 practices in the country that are 10 doctors or more. That's not a lot. And when you're doing an equity deal, it really doesn't cost you any more to do a $10 million deal compared to a $2 million deal. It's really the same amount of work. And the one thing I always say is if you really want to understand dollars and cents in private equity, you have to think of it this way. The private equity guys look at dollars the way we look at paper clips. They're nice to have, but you want to use them to put things together so you can get things done and you can turn them into more paper clips. That's it. So
Mm.
they don't care if it's 2 or 10 because it's the same amount of work. What they care about is how much is it going to become later on. And that's it. Because again, how come, everybody buys boxes of 500 paper clips, yet you're always looking for a paper clip when you need one. It's amazing. And that's really how to think about it, in my opinion.
That's an interesting metaphor, Mike. Thanks for sharing that. So they're really looking at it as money as a tool and not really something as something to be used as a currency, right? More as
Correct.
a tool.
Correct.
Okay.
Because it's
That's
all
very
investable
interesting.
capital for them. That's all it is. It's investable capital.
So do you think that they're looking at you to possibly buy you out at one of those levels of the roll ups?
Oh, they will. I mean, I'd had discussions early on. COVID kind of screwed everything up for a lot of people, myself included. And the difference between being rolled in and being a platform company existed. I don't think the opportunity to be a platform company really exists anymore. I don't think there are going to be any more significant new startups to start rolling up. I think you're running out of practices to find. Actually, still a fragmented profession where there's still lots of one and two doc mom and pop kind of shops, but there's very, very few of me left. They're all been rolled up at this point. So, I'm sitting out there and I'm a little bit of an enigma. So they're busy rolling up one and twosies. And then they come to me and then it's kind of, okay, well, how do we deal with these guys? Because, it's hard enough to deal with one or two personalities. Now you're dealing with, three or four, depending on how many partners are in an organization. And then you have to make sure that when you close, all the other doctors are willing to stay behind because you don't want to buy something that immediately depreciates in value because your units of labor go away. So it's a complicated field. And, I'd like to think that I'm one of the guys on the cutting edge of it. But, there's always new stuff and there's always so much to learn. I learn something new every single day that I do this.
Awesome. Yeah, and speaking of new stuff, you specialize in many different types of foot injuries, foot and ankle surgery, skin disorders, Careflex nail restoration, gait analysis and orthotics, diabetic foot, sports injuries, foot problems. Which is the most common one that you usually treat in your clinics?
So as a practice, we treat everything. That's when it's really there. My
I
focus
understand.
from the portion of myself that has been practicing, and I do 100 to 150 patient encounters a week still, has been focused really on wound care. I'm a wound guy, so I always tease
Wound
that my
care.
yep, I have three kinds of patients: those that have wounds, those that had wounds, or those who will have wounds. That's all I take care of, and it's more of a you can think of it more of as a limb salvage type activity where we're trying to preserve people's feet, prevent amputations, prevent foot loss, kind of maintain independence, maintain ambulation. I always jokingly say that I can't stand sports medicine, and if I have to listen to another whiny runner complain about their toenail again, I might shoot myself. But we have partners in our practice who love that stuff. I'm like, God, and that's the nice thing about being in there is, you were able to maintain patients within the practice and, give them to specialists who are interested in exactly what their problem is to be able to work through them. A lot of doctors won't touch wounds. They're smelly, they're loud, they're annoying. you know, for the most part, they tend to be in much more socioeconomically challenged communities. I don't have a lot of millionaires walking into my door with diabetic foot wounds, for example. And, for me, it's different, it's unique, and you can really make a difference. There's something to be said for being able to save someone's leg when somebody else told them it had to be removed. So, it gives you kind of a warm and funny feeling, and it really kind of makes it worthwhile. But because of that, I also deal with a tremendous amount of emergencies because infections happen very, very quickly. People don't get sick between 8:30 and 4. I wish they did, but they don't. So we get all kinds of calls at different hours of the night and those sort of things. That's the other reason why you need a practice with multiple doctors because I could not do that by myself. Thank goodness I have partners and who take a week at a time. So I'm not on call. When I started in practice, I was on call all day, every day for years, and it was rough. So it's nice to be able to split that up
Absolutely. I have a question about foot injury. Do you deal with any gout
all the time.
injuries?
All the time. I can't tell you how many times a year I get called to treat somebody with cellulitis where it's actually gout because they look very similar.
Really?
Yeah,
And
so
is
they'll
that
get
still
admitted.
considered the rich man's disease?
Well, the disease of kings is what it was, and there's some literature that suggests that might not actually be true. It was always considered that foods are high in purines were what actually produced the uric acid, leading to the crystallization and gouty attack, and that was organ meats and cheeses and shellfish and kind of expensive type foods. There is some literature that suggests that might not be true, although it is still widely accepted that purine diet is and to reduce purines in your diet. So yes, if you're eating shrimp and crab every day, you're probably going to have a gout attack. When I was a resident, I had
Oh,
one attending say that Baltimore was the gout capital of the world because of all the crabs and beer people ate
I
here.
was just gonna say you got the Maryland crab all over the place over there.
Yes. I live in the one place where when somebody says, "Ooh, you got crabs," it's not a bad thing.
That's hilarious. Okay, how long does it take to heal gout? Let's go on to that.
So if you're properly diagnosed and you're given medicine immediately, you can be better almost instantly. It's an
Yeah,
inflammatory process, so you have to stop the inflammation. So my initial go-to for gout is oral steroids on the outpatient setting, or IM or HIV steroids on in the hospital setting, because usually within an hour people feel better. It just stops the inflammation process.
wow.
Whether or not you have a high uric acid or hyperuricemia that has to be treated is something that has to be worked on. It requires a blood test. But, there some people produce too much of it. Some people don't excrete enough of it. You see it a lot in patients with kidney disease. You see it a lot in patients who are on antihypertensive medications, all of those things. But, we see, I see a couple of cases of gout a month. It's not like every single day we see it, but I see it quite a bit. And then, we have other things like pseudo gout, which is gout, but it's non-hyperuricemic. So it's caused by a different type of crystal that can form in a joint. You can have very similar and gets treated very similarly too, but it's not with uric acid, those sort of issues that we see from time to time. And then, septic arthritis can look like it. Something called Charcot-osteoarthritis can look like it. There's a bunch of conditions that can mimic it as well. So most of the time, we're getting called because these people are in the hospital because they came in with a red, warm, painful joint and they got diagnosed with cellulitis and they're sitting there on antibiotics, not getting any better because they're not affected.
Of course, yeah. And now, what is the biggest goal for the business in this calendar year of 2026, Dr.
Well,
Daniels?
again, at this point in my career, the ultimate goal is profitability. We just want to maintain profitability. Everything is getting more expensive. Everything is getting harder. Everything is getting more difficult. And our reimbursement from insurance is not keeping up. So
Mm,
in 2025, we actually had a 2.8% Medicare cut. So in 25, we got paid less than we did in 24 for the same services. This year, they gave us what's supposed to be a 2.5% bump. So it doesn't even cover what they cut previously. And it's not because of the way it's formulated. The way it's actually formulated, it's more like 2.1%. So we're still not making the same dollars we did in 2024 for the same services from our
of
Medicare
course.
population. Yet, I don't know about you, but my electric bill has gone up and all my rents went up 3% every year. And,
Mm,
everybody's wages go up and healthcare goes up. Everything gets more expensive. So just maintaining profitability has become a major, major goal because we want to work smarter and not harder. And the way we've done this over the years is to actually increase the number of service lines available in our practice. Old time medicine, old time podiatry used to be see more patients, see more patients, see more. Well, there's only so many hours in the day. And, if you're just seeing more patients, you're just getting, less money for each patient. It's not an even game. So the way we look at it is we sit down and we try to figure out what are our patients going outside of our practice to get? Where are we sending them for things? What are they getting? What are they paying for? And we try to bring those things into the practice. So we try to capture those revenue dollars. And that's how we're able to maintain is adding these service lines to our practice instead of just trying to pile more and more people on the schedule.
Okay. That makes sense. Now, thanks for helping me get that goal of maintaining profitability for this year. Now we've talked about the origin story, what's working, what's not working. I want to kind of shift to where the strain and the chaos shows up. If you look right now as the president, what your current patient acquisition process is, what is the first point of friction or strain that your team feels every single day?
Telephones.
Telephones. What about
Hands
telephones?
down. So the majority of practice of patient interactions start on the phone. Even in the day with we have patients who can text, we email, we have chat bots, the whole nine yards. It's still the telephone. So the first problem is having somebody on human answer the phone. Nobody likes talking to robots. AI is everywhere. We attempted to use AI for answering the phone. It was a colossal disaster. You probably could do a whole podcast on AI and phones, but
What
uh,
happens? Please tell
yeah,
us.
people hate it. They start cursing at the AI. They don't realize those are transcribed. So, you have this little 90-year-old patient who's sitting there dropping F-bombs on your AI. And it's almost like
And
you're
you're getting that
shocked.
transcript
And
later
we get the
like, "Oh my
transcript and
god."
we know it. So you're like, oh my God, they're so sweet. We've known them for years. Oh my, and it's eye-opening. So, we do want people to answer our phones. So, our phones, the way it is you call any one of our phone numbers and it rings at every single front desk in every office. Somebody should be able to pick it up at any given time. We have, seven or eight people who are supposed to pick up the phone, yet we still miss 40% of our phone calls. They go
Oh,
to voicemail.
wow, still?
But then we get 10,000 calls a month. So how many people would we need to answer the phone 10,000 times? And again, not all of those are patient calls. There are telemarketing calls. There are wrong number calls. There are people who want to order pizza. People, there's calls for everything. We do, within our marketing strategy, we actually monitor all of this. And there's some different strategies that we do to discern where things are coming from and what's working and those sort of things, as most businesses do. But the telephones is the greatest line of friction because first thing is you have to get somebody on the phone. And then when you get somebody on the phone, you have two people who don't know each other, who are probably from very different backgrounds, trying to have a meeting of the minds. And that's not always possible. Even when the intent is good, the patient wants an appointment and the employee wants to give them an appointment. Sometimes there ends up being friction. And while I think attitude from a person is much easier to discern in public, on a phone, sometimes people start to kind of get, I call it uppity. And we tell our employees that if you're ever on the phone arguing with a patient, you're wrong. I don't care what they said. It doesn't matter if they told you you were green and had four hands. You say thank you. They're the
The
customer. At
customer
the
is
end of the
always
day,
right.
they're the customer. You do not argue with customers. And listen, some people are naturally conversational. I'm sure you've met some in your life. It's just something you can do. But if we could find a smoother, better way to answer our phones, I think that would be a huge, huge improvement. And I think that would move us along a little bit better. There is nothing worse than being stuck in a 10 by 10 room with the door closed and somebody yelling at me because they had trouble with the phone. And I'm like, I didn't answer it. I'm so sorry.
Thanks
I
so
don't,
much for sharing that,
yeah,
Mike. I
yeah.
really appreciate that. Let's move to the next question. How do you ensure that every single lead from an initial inquiry to a booked consultation is followed up on consistently? And follow up, what percentage of leads do you feel are slipping through the cracks?
So I will tell you that we have some redundancies built in to try to find people. So, for example, if you end a call without having spoken to somebody, that means either not leaving a message or not having a conversation, you get an immediate text message back that says, "Oh, we're sorry we missed your call. We can communicate with you this way. How would you like to go?"
That's
We
good.
do communicate, by email for those things or by portal. You can do it through our patient portal. So we're trying to follow up on those. Our lead generators are from the web. They're obviously form fills. So we get emailed the form fills. So we can follow up with them that way. When somebody says something, we take information. And then we have the broadcast. We have a whole bunch of social media that we do and constant contact newsletters and those sort of things to get it. So, we're constantly trying to look and track down those calls. But what we can't do is the people who call, they get the beginning of the message. It's not a real person. They hang up and don't answer the text message and go call somebody else. Or over the years, we've had problems with phones where people, I call them going off into the ether. They claim to have left a message somewhere. We don't know where it is. We can't find it. We try to find out which number they called because over the years, we've accumulated about 50 different phone numbers for the practice during practice acquisitions, buying numbers, et cetera, et cetera. So, we never know what anybody has. So we try to find out what number they dialed to see if there's a directory somewhere where some back tree took it to some mailbox we don't know about. Because there's nothing worse than somebody telling them they didn't get a call back when they were told they would. A
Yeah.
broken promise is a broken practice, and it's real important that they do that. But unfortunately, the people who answer my phones are usually the lowest level employees on my totem pole. And, there's a reason they're there. Most of them, it's starter jobs where,
Hmm.
they're going to work their way up to bigger things. For some people, it's just, that's the level of work that they want to put themselves through. Because, I say all the time, work is a 4-letter word. There are lots of other 4-letter words we don't want to talk about. Work might be on that list soon. So that's really kind of where you have those problems. And it boils down to, getting on the phone and then the interpersonality conflicts that tend to come up between people for really the dumbest reason. I don't know why you'd ever call someplace and be adversarial towards somebody. Even if you're going to be the customer, you still want to be the customer. You
Hmm.
should, want to get along with everybody. So I don't know. I try to get along with everybody. So I don't really know. But that's the biggest friction. And I would say, if I had to think about it, probably 30 or 40% of our phone calls are not patient related, direct patient appointment related calls. And we probably lose between a quarter and a half of those. So I guess if you break it down, it's probably between 10 and 15% of phone calls that we're not answering that are lost patient opportunities.
And do you think shoring up those numbers would increase the overall profitability of the practices?
It could. We're pretty busy and busting at the seams. So it's not a matter of, would we have more visits? It's kind of where would we put them? Because we also try to operate on basically a same day, next day for appointments. Because, when your foot hurts, you don't want to wait till a week from next Thursday to come in.
Hmm.
Or you might go to urgent care by then. It might feel better by then, all kinds of things. So we try to get people in right away and it keeps
Yeah.
us all very busy. And I would love nothing more than to have to hire more doctors, except it's impossible to find them. There's just not enough doctors. We're not producing enough podiatrists in this country. And that's the same through all medical specialties, basically. Just this morning, I was in the emergency room and I was talking to one of the emergency room doctors, and they're not even filling all of their residency slots. So there are open slots for training in emergency medicine that aren't getting filled, which is incredible because
Wow.
I couldn't be an ED doc, but still, you would think that there would be enough with the American med graduates and then the backfill from foreign med graduates who want to come here to be doctors, that they would be able to fill them. And they're having trouble filling the EM spots.
Well, I think that's definitely something to take note of, and perhaps our audience will be able to take action on that. Thanks for sharing that insight. We really appreciate that. If you could eliminate one time sink other than the phones that you previously mentioned, or a repetitive task that distracts your most highly paid staff, not just the people that answer the phones, they're the lowest on the totem pole, as you said, but the most highly paid staff, like the doctors and the nurses, from delivering patient care, what would that be?
So I talk to people about this a lot, and everybody has a problem with their health insurance, whether it's the provider, whether it's the patient. Everybody hates their health insurance. But if you think about it from a business standpoint, whomever set up health insurance is an evil genius. Because if you think about it this way, you come to see me as a patient, right? I take
Yeah.
care of you, we interact. I send the bill to a third person. That third person decides how much they're going to pay me and decides if you're going to pay me direct. So they send me check and they send you an EOB that says you owe the practice. So then I send you a bill and you're mad at me for sending you a bill, not the person who told you you had the bill. Me. Name one other profession where it works like that.
Yeah.
It doesn't exist. It's brilliant. No, everybody hates their insurance company, but nobody blames them. They blame the doctors. So, you run into those sort of things. That's the biggest problem we have. That, and then the understanding of how to go from treating a patient to properly documenting the visit to being able to bill correctly to generate the revenue you're supposed to generate for those visits because of what you actually perform.
Mhm.
The second way that insurance companies are absolutely brilliant is they took the one thing that doctors despise. Find one doctor that says, I love doing documentation. You will not. If you do, then you probably should call somebody because I've never met a doctor in my life that wants to document. But they made your entire income dependent on it. So you're
Oh, wow.
absolutely 100% dependent on something you despise doing to make a living. It's the bizarrest system that you will ever see. Because remember, for the most part, we don't get paid by patients. We get paid by insurance companies. They may have
Yeah.
copays, they may have deductibles, whatever. But even if you have a copay or deductible, the amount that you have to pay me is determined by a third party. So
Mm.
it becomes very, very difficult. And that constant need to put enough information into your documentation, not to satisfy what you need to know next time the patient comes in to be able to read, but to make the requirements for all of these skilled points and all of these missing points and all of these bullet points, all these things, some of which are pretty much irrelevant and have nothing to do with what you actually need, but they're in the notes because they're required by insurance. And to finish this up is when you document things for Medicare, for CMS, and you have an audit, they have a perfection or repay system. So if they have a system, a thing, and you need to put 20 things in your notes to be able to bill that service, and you only have 19, they will take the money back. Doesn't matter if you did the service. Doesn't matter if it was medically necessary. Doesn't
Mhm.
matter how much it cost me. If everything isn't in there, they take the money back. That's an unfair standard. That's a perfection standard. Name one other profession where perfection is the only metric, and that's what you
Wow.
got.
Yeah, I don't know, I guess, and that's their standard. Wow, that's very interesting. Wow. Well, I wanna talk about future goals now. Next 2 to 3 years, the biggest strategic moves that you're planning, and you mentioned the goal for this year is to maintain profitability, to cover overhead costs, obviously, some of that shrinking margin from the insurance companies, and obviously increasing bills that are coming up, like electricity and costs and staff. If you looked at the business today, what's the single heaviest anchor that's dragging that process down? What's one broken system that, if fixed, would solve half the other problems on the list?
So the thing that's most broken is the thing that we can't fix, and that is labor costs. It is
Labor
impossible
costs.
because, again, if you want to generate more money, then you're either doing more service lines, which requires people, or you're staying open later to see more patients, which requires people.
Mhm.
And those labor costs are our number one thing on our P&L is labor. That is the number one cost that we have. And the system has been slightly rigged against small business without in any way, shape, or form getting too political. We had a push to 15 here several years ago where the General Assembly passed a $15 an hour minimum wage and they
Okay.
phased it in over, it was like 6 or 7 years. So, we as
Okay.
small businesses where you gear up. Our current governor, when he came into office, accelerated it 2 years. So all of a sudden, overnight, a whole bunch of people got raises and a whole bunch of people were suddenly making minimum wage because people who, when we had it at 12 and people who were at 15 or $16 an hour, now when the minimum is 15, are not so happy anymore. So you can't leave them on the lower end of the wage scale. They have to be bumped up accordingly too. And that, where we go back and refer to the increasing costs and the declining revenue sources, has really put a squeeze. That's my single problem. And it's not like I could say,
I just want to clarify, it's not a system process problem, it's a people problem. Is that right?
it is because we can't send them home to save money. They have families. They need to pay their rent. They need
Right.
their hours. So, it creates a huge strain on everybody. Everything goes up in price. If your McDonald's is now paying their $15 an hour, the McDonald's prices go up. So everything rises. And I'm not saying we shouldn't have a $15 minimum wage. Don't misunderstand me. But, when they announce how it's going to be phased in and you start to look at problems and then they change that overnight, well, you just have to adapt. And it's too bad if you can't. There's no assistance programs, there's no ad programs, there's nothing that allows you to change that. So,
Mhm.
that's the biggest thing. And, we have been trying to get, what we call lean and mean and do it with as few people as we have without outsourcing. Because I really didn't want to have my employees not have jobs because we were using somebody from, the Philippines or Colombia or India, where these, because I get companies that want to suddenly outsourcing to do everything every single day for fractions of an hour of what I pay for most of my employees.
Uh-huh.
But, again, we're trying to employ people in our community and we want to keep doing that. I think that's, the civically responsible thing to do. But, it becomes more and more difficult to do that every single day.
Yeah. And that's been a fantastic breakdown, Dr. Daniels. And I really appreciate you for being so candid about your operational reality. I think we've covered a lot of ground today from your origin story to the future of aesthetic medicine. And I know that our audience will get immense value from this. So thank you so much for sharing the information on the insurance company and on the PE roll ups. That was very enlightening personally to me. And thank you so much for your time.
We
With that,
appreciate you
we're gonna
inviting me.
go
Thank you.
absolutely. With that, we're gonna go ahead and wrap up the recorded portion of the Growth Lab.